Hi, everyone. Thank you very much for being here. Thank you for the invitation as well. This has been I've been very impressed up until now to hear all of these stories and all of the speakers. So thank you very much for having me today. So I'm not a doctor. Am I the only one in the room? I don't know, but I'm a computer scientist. So I'm on the other side. I'd like to tell you a little bit more about what diagnosis means, maybe with a bit more rational thinking, and where is it today in terms of science and math and computing. What can we do in order to get faster with this? So I work at Mendelian. I'm the founder of Mendelian, which is a tool that's been mentioned already. And we're really into the diagnosis of rare disease. So we look at accelerating streamlining the pathway and the patient to diagnosis. So I'm not going to go through this because we've talked about it a lot. And I think the diagnostic odyssey is pretty clear, whether it's from the patient side or in the healthcare system. I think maybe something that we've talked slightly less about, but we still hear it, but it's the idea of the equity of care. And I think it's the equity of care regarding diagnosis in rare diseases is still a pretty big of an issue, because we keep talking about centers of excellence and great doctors that know a lot about these diseases, but realistically, how many experts do we have per disease in the UK? So if you live in London and you're in front of Gosh Hospital, then it's great, but if you're not, then that becomes much more difficult. And so I think I'll tell you more about this and how I think that technology is also playing a role in there, just leveling the playing field really for the equity of care. So if we look at the problem itself, the rare disease diagnosis being as an issue, we like to think about it as an information challenge. So the information is out there, it's just that it's very fragmented, very disorganized, always out of date. And so in a way, if you think about it, humans are really not the best fit for a problem like this. And so we've been very good at pattern matching for a long time, and we have incredible doctors that spend a long time trying to get as much information on this. But it's a bit of a nightmare for the human brain, right? So if we look at what are the assets that we need and what is it that we need in order to go faster for these diagnoses, then we have to look a little bit around what's happening in the computing world. And in the computing world, this is what we have. We have a massive processor, which allows us to understand the underlying patterns, the things that we don't get to see. We also have massive memory. And that's very important, right? Because there's no maximum to the amount of information that you can feed a model and a computer. It's also unbiased, and I think it's important to mention this. It's been mentioned already, but systems like ours really shine with diseases that are progressive and that are multi-systemic. So if we've mentioned it again, right? Rare diseases, there's a symptoms here, and then 2 years later another one, and then 5 years later another one. We can't ask doctors to be looking at the full history every time, especially if it comes from different systems, and if it's one time it's the cardiologist and then it's the neurologist. The computer, in a way, doesn't really care. They don't have a specialty. They look at it completely holistically and say, okay, this is the system that I see, and this is what we're probably not seeing here. And finally, there's up to date. That's a very important component to what we do. So, I think in the literature, we discover about 5 new rare diseases per week. There's this number out there. This is just mind-blowing. You can be the biggest consultant in the world. If you haven't read your paper 2 weeks ago, you're already late on what's happening. And this is just, again, we can't really ask doctors to be up to date. So computers, they're constantly connected, so up-to-date information that are being fed to them. So it's easier for them. So when we looked at that, we said, okay, there's clearly something that we can do. And so we started working on this tool, this digital engine. And it looks a lot like a search engine. You feed in some data, some signs and some symptoms, and then the machine starts computing some numbers and then comes out with some results. And these results are diseases or genes or mutations that may be causative of the symptoms that were entered. And so the way I describe this usually is the goal here is for the machine to find underlying patterns. So the way we do this is we extract as much information as we can. We curate, we sort, we store it into a big knowledge graph, a little bit like a brain, of all of these biological components that are talking to each other. It can be signs, it can be protein, genes, and we understand how they are linked with one another. And then on top of this, we put some mathematical models that allows us to query this brain, to query this knowledge base. And then we provide answers to whoever would need it the most. And so I've had planned to do a bit of a quick demo, but maybe if we can switch, Steve, I'll just show you. So I think you've seen this, but I just want to show you how straightforward this is. So that's just a web browser, right? So this is something that everyone has access to all the time on a web browser. That can be done on mobile as well. It's very easy. You get on this app, this tool, and then you would start by typing, describing your patient, right? So I don't know, let's say epilepsy, and then maybe cardiomegaly or some sort of ataxia. I have no idea here when I'm typing, obviously. And here, the moment I press search, you'll see that this is what's happening. You see there's a bit of loading some results, and here are the results. Each card here is a disease. All of them have a relevant gene that is associated to this disease. You have description for this disease. You even have the number of cases maybe that's been published, the sources of information, where is it that we found it? Is it from a research paper? Is it from OMIM? Is it from a specific database? So by clicking here, I get to know more clinical features as well. What is it that I may have missed? What is it that this disease and this patient may have? Here on the left, you see that this is all of the clinical profile, the information that I have about this patient. And so again, here I've entered only 3, but we have doctors that enter 10, 20, 30 clinical features. And here the idea is really to provide a differential diagnosis and to guide the clinician to things that they not have seen before. And so, I've shown this tool to a lot of clinicians, and usually the way they go when we show this to them, first they don't believe in it, and that's fine. So we say, okay, let's try it with a patient. And so they go into their drawer, they get some patient, they start entering the symptoms, and then the results come out. And something interesting happens. First, they'll dismiss a couple. They'll say, no, the first one doesn't make sense. The second one I've thought of already. This one is not relevant. But then something happened. They will see a disease that they've never seen before, that they've never even heard of. And this is really where they flip. This is really where they understand the power of the tool. So this tool is being updated every day, every night. We go out there, we scrape some information, we're bringing in, and then the models run again. So if you put these symptoms today, and in a month from now, the results that you see here will be different. So there's a notification system that we send to doctors, whereas when they save a patient and say, this is the patient look like today, if 6 months from now, there's a new research paper that comes in that talks about a patient that looks a lot like what they've described, it's a push of a button for us to notify these doctors about the new results that we have. The obvious question here is then, okay, how much does it work? Is it working? How do you know if it's working? So there's a lot of work that needs to be done on the benchmarking. And when we do these kind of tools, data scientists, they like to think about benchmarking in different ways. You first have to do it on synthetic patients, or fake patients. You come up with clinical signs, and then you see if what you're looking for is really there. And then you get to real patients, and you say, okay, what if we take a data set that is existing of patients that we can look at? Is this good? And you calculate the accuracy. You give 3 signs, you give 5 signs to the machine, and then you see where is the disease that they're outputting in the rank. Is it first? Is it fifth? Is it 50th? How good is this? Can you do this over 100 patients? Can you add a bit of noise maybe? Because the patients are never just 5 clinical signs. What if we add 2 random signs as well? The signs that they may not have at all. Let's understand if this is linked to the disease or not, and let's see where the disease ranks again. So we had to work a lot on what we call robustness to noise and imprecision. Again, when the doctor looks at you and gets to describe some clinical signs, they may not describe exactly what the sign is that is associated to this disease. Maybe they're describing something a little bit more general or a little bit more specific. So again, the machine needs to understand this, and this is what we call imprecision. And so as we go through the different benchmarking that we do, from fake to real, and then starting asking doctors, we start distributing this tool, understanding if doctors actually find it useful, how many case reports do we have patients that are being diagnosed through the tool, and so we keep moving. And at some point, the kind of the golden validation is always going to be having more than one doctors independently looking at this tool. And so this is where we're going little by little. There's been this white paper that we published about 2 months ago now, that talks about the validation study. And we're doing this against a board of 11 expert clinicians. So they had 3 weeks to look at about 100 patients and generate differential diagnosis for all of them, looking at the symptoms, looking at the signs, and then providing a list of 150 genes or diseases. And they come up with, I think, a very impressive accuracy. I think it was around 82. Now, we gave this to the machine. The machine, it took it about 7 seconds to get to the same results. And we got to 84% accuracy. But this is really not the conclusion that I want to make about this. What I want to try to say is the moment we overlapped the predictions of the doctors with the prediction of the machines, then we got to an accuracy of 92%. And this is really what we're talking about here. It's not that much about comparing what doctors can do or what the machine can do. It's about comparing what doctors can do versus what doctors with the machine can do. And this is very important for me to emphasize. And I think this is where I will loop it back to the equity of care. You have to remember, these were 11 experts. Where do we have 11 experts today in the world? And when is it that when we go to the doctor, we believe that there's going to be 11 experts that are looking at our case? It basically never happens. So here again, we're leveling the playing field so that doctors that are not expert have access to at least a bit clues that would put them into the right place and start their investigation in the right way. So I think we've been live for about a year now. We've put this online just to see what doctors would want, and it's a tool. It's free. It's out there. We have more than 2,500 registration for the doctors. We've been used in many different universities, really around the world. I think it's from 150 countries. So it's pretty nice. And again, we keep talking about equity of care because it's the NHS long-term plan, but let's talk about equity of care globally as well. We have doctors that are using this in India, in Russia, in people that we've never met that don't even know about us. But they go online, they start typing signs and symptoms, and they're streamlining the diagnosis process of their patients in places that we would have never gone and put this in front of them. So it's an interesting step right now in the life of this project. We just won a great Innovate UK grant. So the government is really helping us to push through this. And the big question we have now is, what can we do at scale? Because we're not going to go and knock on doors of all of the GP or secondary care doctors. It's just not going to work. So is there something else that we can do by maybe looking at many more patients, focusing on a couple of diseases and say, okay, can we screen these patients? Can we flag them? Is there a way to, again, put them into the attention of the doctor? And we have to be very careful because flags, doctors don't like it very much. If we start flagging for all rare disease, then everyone would have one. So we have to be a bit careful, but it's very encouraging to see that the government is helping us do this. So I'll give you an update maybe next year about where we are about this. So yeah, I think that's it. In terms of conclusion, I mean, this is really the mission of what we do, and I'd be very happy to open a conversation about this because sometimes it's a bit of a tricky subject, right? But diagnosis should be done more with the help of computers, and that's pretty obvious to us, and at least I would say to also the new generations of doctors that are coming in. So they're much simpler problems for computers, and they're very difficult problems for humans. So there's something that we can do here, and if these things are done right, I think doctors will gradually do less of diagnosis and more of what they are definitely the best at, and that the computers will never be able to surpass them, which is treating and caring for their patients. Thank you very much.